Hello everyone, my name is Lila Mayahi. I'm a consultant physician in clinical pharmacology, acute medicine and obstetric medicine, and I'm also a co-lead in obstetric medicine for the Southwest London and Surrey Heartlands. I hope the next half an hour provides you with some information and some knowledge on medication use in early pregnancy. So the aims and objectives for this session are to go through some basics of clinical pharmacology, to also go through some physiological changes that may impact these pharmacological entities, and then briefly go through stages of fetal development and how that may inform us about use of drugs at different stages. Talk a little bit about risks and benefits, obviously, in any setting when we're prescribing or taking a history. We're always aware of the individual in front of us and what we would be prescribing for them with regards to the side effects, the contraindications, and the benefits for that individual. And ultimately, as we all know, at the end of the day, if you have a healthy mother, you are more likely to end up with a healthy mum and a baby at the end of the pregnancy. I'd also have a few cases at the latter part of this talk that I'm hoping they would provide some examples for you into your clinical practice. So briefly starting with some revision on pharmacology, broadly the way pharmacology works within body is through probably three main topics of pharmacokinetics, pharmacodynamics and pharmacogenetics. With regards to the pharmacokinetics, I'm sure you're all familiar with the different stages of this, starting with absorption, which is the first stage, where medication enter the body and travel to the site of administration into body circulation. Distribution is the process by which medication is spread throughout the body, and metabolism is the third stage, where the breakdown of the drug molecule occurs. And then finally, the drug is excreted, and that could be through mainly kidneys, but it could also be done through the gut. Other things of consideration, obviously, are going to be pharmacodynamics, and this is the way the drug in the body is acting on various different receptors. It's about the binding and potency of the drug. And finally, pharmacogenetics, which is a topical area these days with regards to each individual and the way that we are made up with our genes, handling bodies differently. And you may be aware that there is a lot of pharmacogenomic study going on with regards to how different individuals may respond differently to a certain drug within the domains of appropriate treatment for a disease. Now, this is just a picture to remind you that when we're talking about pharmacokinetics in pregnancy, we're not just talking about handling of the drugs by the mother, but also the fetus, and not forgetting that placenta itself is an organ that is able to metabolize and excrete drugs. So on this side, sorry, I think my picture may be on on the top of this diagram, but essentially the darker arrows are suggesting the entry, the absorption of the drugs, and the lighter no-filled arrows are suggesting that there is excretion and metabolism going on. And as you can see within the mum, the placenta and fetus, all those processes are occurring. But essentially, because of the physiological changes in pregnancy that I believe one of your earlier lectures today would have covered, there are going to be some changes within the pharmacokinetics of drugs. So in summary, this table is going through what parameters may change, such as gastric emptying and change in the gastric pH, which may alter bioavailability of the drug, because the drug may be hanging around in the gut for a bit longer, giving it a bit more time for it to be absorbed. The time to its peak may be different, and also if it is a drug that will not like being in a acidic environment, it may not have the desired effects if it's exposed for too long to acid, and vice versa. As a result of increasing cardiovascular output, there is increased in blood flow to all organs. Therefore, if the drug is being broken down in the liver, then there will be an increased metabolism. If it is eliminated and excreted through the kidneys, the blood flow to the kidneys is increased, the renal excretion is increased, therefore you would get rid of that drug a lot quicker. Again, there is increase in plasma volume, and that can alter the distribution of the drug throughout the body, particularly depending on the affinity of the drug, whether it binds to lipids or whether it's water soluble. And the same is true by drugs that are bound to albumin. They are carried in the body system by being bound to a protein, and that could also affect the distribution of the drugs and the availability of the free drug in the system. We've already mentioned about blood flow to the liver that increases, and that may increase metabolism, but also to mention that there is change in certain enzymes within the liver that handle drugs and drugs breakdown, and of course that could also be an element that one needs to consider. Now, having said all of that, there is lack of data, there is lack of studies to understand whether each of them have a significant effect on how we handle drugs within pregnancy and the outcome. Suffice to say that you may be familiar with some drugs that definitely have changes in their pharmacological distribution, and we need to do levels on them, or we need to look at the end organ effect and perhaps increase or reduce them during pregnancy. Examples of those would be things like thyroxine for patients who have got hypothyroidism, or some of the anti-epileptic medications during the second or the third trimester, when you may need to increase the doses. Now, turning our attention to the way we think about prescribing, and this goes for principle of prescribing in any setting, not just pregnancy. I think we've talked about risks and benefits already, but I'm going to go through it systematically, that when a drug is chosen to be given to any patient, by and large, we're looking at its efficacy, which is this drug going to do what it's meant to be doing, and is this the best that we could do for our patients? So when you evaluate a new drug that is entered into the market, you will be looking to see whether it is better than the existing drug, and making those choices accordingly to the efficacy of the drug, to the safety of the drug. So we've talked about risks and benefits. We're also talking about its convenience of route of administration. So is it acceptable for the patients to take injectables? Is it acceptable to have 3 injections a day? Is it acceptable to go with a drug that may have lots of side effects? Do they want to take the drug once a day as opposed to 4 times a day? The element of cost effectiveness is, in this country particularly, is taken out of our hands as drugs enter national formularies after they have been reviewed and deemed to be cost effective. We generally avoid polypharmacy. We tend to not go for newer drugs and go for drugs that have got longer term data, particularly in the pregnant population. And by and large, we choose the lowest, most effective dose for the shortest possible time. Again, this theme of if you have a healthy mother, you will end up with a healthy mother and baby at the end will feature in this talk throughout. Now, if you think about the risk of exposure to drugs, I have divided the fetal development into 3 very well phases. This is pre-embryonic, embryonic, and fetal phase, and then labour and breastfeeding, which I will not be talking about much in this talk. This is a pictorial representation of the period where fetal development and structural development are very sensitive, and that's depicted by the blue bars, and less sensitive periods where perhaps functional development is more at stake, as opposed to anatomical development is depicted by this grey-greeny shades of the bars. And you can see that in the first 8 weeks of pregnancy, there is a highly sensitive period where the effect on anatomical development could be significant, and the latter part of pregnancy, that's less of an issue. I'd like to then go through when you are taking a history, which is very important in your assessment of your pregnant woman during their first antenatal encounter with you, or indeed at any stage when you come across a pregnant woman, to ensure that you have a good grounding of what it is that they are taking, what dose they are taking, how they're taking it, and are they adhering to it. And then to be thinking about, is the drug that they are taking teratogen or harmful to the mother or the baby? Then to think about whether the drug needs to be continued or started, and then whether there are alternative safe drugs to use, and what additional precautions need to be taken, and of course how far in the pregnancy the woman may be. Just to demystify some of the blames that are given to the drugs for anatomical abnormality or fetotoxicity, it is, I'm sure, very, very well known to this audience that there are a lot of miscarriages that happen in pregnancies, and there is a fair amount of birth defects that are seen in UK, and this is the data, probably a bit of an old data, but still holds true. And 75% of these birth defects are of unknown causes, and 25% of them are associated with genetic abnormalities. And out of those, about 10% are associated with chronic maternal illness. Those would be things like diabetes, congenital heart disease, or congenital infections. So blaming these outcomes, malformation, on drugs may be inappropriate thoughts. So as per the diagram that was shown earlier on, I hope you appreciate that the most risk-associated period for anatomical development are in the first trimester, and then thereafter it's more about how it may affect the growth or behavior, neurobiological development, or indeed at the end of the pregnancy and during labour, and perhaps breastfeeding, more about neonatal toxicity. So drugs in pregnancy can be divided into drugs that are completely to be avoided, so known teratogens, for example, things like warfarin, sodium valproate, which has been highly publicly talked about since particularly 2018, and there is ongoing conversations at the high level and public health area to ensure it's avoided to be prescribed for any woman of childbearing age and during their pregnancy. There are drugs that are relatively contraindicated because there are some theoretical data, there may be some animal studies or no studies at all, but looking at their way they work or pharmacology of it, and maybe case reports, it is has relative contraindication. So example of those would be perhaps diuretics early on in pregnancy, although that if you would need it because the mother needs it to survive, then you would be using it. And then drugs that are known to be safe in pregnancy, again through tried use of it for many years, clinical outcomes, national surveillance, national registries, etc. But nothing's going to help us more than actually having some knowledge of the drug safety, and obviously that is very difficult to know every single drug that every woman may present with from the beginning of their pregnancy. So, and it's not expected that people would know that, but it's important to recognize why they're taking what they're taking and whether it's important to continue, and perhaps seek help when it's unknown. So, as mentioned before, taking a good drug history is incredibly important. So it's really important to ensure what prescribed medication they should be on, what the doses of those are. So often there is a relationship between the dose of the drug that they take and the outcomes. Talking about adherence, lots of women, as you know more than me, will stop their medication regardless of how severe their disease may be, for the fear of harming their unborn baby. It's really important to also take account of over-the-counter medication, any herbal or homeopathic medication, and of course their drug allergy. So I'm going to spend the next 10 minutes or so going through some cases which I hope you will find helpful. So the first case is of a lady with severe asthma who's now presented with exacerbation of her asthma. She's 13 weeks pregnant, and she's concerned that the steroid and nebulizer bronchodilators that have been prescribed for her are going to be safe for her baby. So we're going to go through the stages that we've talked about, whether the drug that we're prescribing is teratogen, whether she needs to be on them, what alternatives there may be, and at what stage of her pregnancy she is at. So, are steroids safe in pregnancy? Well, there is an awful lot of data out there that steroids are being prescribed and used in pregnancy, and the safety data is very supportive. There are some data about some cleft palate, but by and large, we barely see those currently. And if it is required to have steroid treatment in order to ensure safety of the mother, they should be prescribed. Certainly, there is no data to suggest unsafe use of inhaled steroids. And at 13 weeks of pregnancy, really most of anatomical features are built in the fetus. What may be the adverse outcomes? So we need to ensure that we can relay the message that actually only about 10% of the steroid gets through the baby, because placenta actually is able to metabolize most of it. And if the woman needs it, the risks of her being unwell with hypoxemia are far greater to the developing babies than actually taking any steroids. There is some theoretical data that there may be adrenal suppression for the baby. There is very little data on that, but by and large it depends on how much for how long of the steroids they would be taking. And other things to mention is if they, for themselves as the mother, if they continue taking steroids for a longer period of time, so actually if they have taken greater than, it's 5 milligrams rather than 7.5 milligrams, I apologise, that should have been corrected, for greater than 4 weeks during their pregnancy, we need to be aware of that and ensure that they have replacement therapy during time of labour and delivery, where there is a stressor's demand on adrenals. For the woman, obviously, we need to be careful about their sugar levels, their glucose levels, and at this stage of pregnancy, perhaps not as important, 13 weeks, but we know that exposure to steroid for long term has association with development of diabetes. Nebulized beta-2 agonists such as salbutamol and inhaled salbutamol are very safe in pregnancy, as are other asthma medications. So you could be reassured and reassure your clients that all asthma medications are pretty safe in pregnancy. So the second case is a case of a 25-year-old with epilepsy who's on lamotrigine, and she is in her antenatal booking, and she is incredibly concerned about continuing with this, although she understands the importance of having a good control of her epilepsy. This is straight lifted up from the Medicines and Health Products Regulatory Agency website, where this is published, that the agreed medication for epilepsy treatment is now well recognized that lamotrigine and levetiracetam are safe in pregnancy, with no risk of a major congenital malformation associated with them. There is a lot of data now, with the caveat that you need to be counselling the woman, that it's very important to understand the importance of continuing to adhere to the drugs. It's also important to understand their epilepsy syndrome. It's important that they're engaged with their epilepsy team and they are put in the joint epilepsy and obstetric care. You hope that they would have received some pre-pregnancy counselling, but at every encounter it's really important to be able to reassure the woman of safety of their anti-epileptic medication and importance of adhering to them, and also giving them information that if they usually get an aura before they have a fit, if they were to start experiencing that, that may suggest that the dosage of their medication may need to be changed. So those are the things that I have already mentioned. I suppose the only other thing to mention, that these women obviously get more frequent scans to ensure about any anomaly that may be a case, although in lamotrigine case and levetiracetam we know that that's not the case. The other thing is to ensure that they have they're on board with taking their folic acid, although lamotrigine, levetiracetam are not associated with reduction in folic acid production. They are not folic acid inhibitors or antagonists. The third case is of a older lady who has type 2 diabetes and is on sitagliptin and is wondering whether she should continue with it. Now, sitagliptin may be a drug which is less familiar to this audience. It's one of the oral anti-epileptic medication. It's used as a second-line treatment after metformin, but it may be that this lady was not able to tolerate metformin or has decided to go for this medication. So the data for these medication outside pregnancy are such that they should not be used, and the only medication used in pregnancy at the moment in most cases with good safety data is metformin and insulin. So not all oral hypoglycemics are recommended in pregnancy. We know about metformin, which is a biguanide, and it's safe. We know about insulin. But obviously, we need to counsel this woman how uncontrolled diabetes itself has an association with congenital abnormalities and complications in pregnancy, about macrosomia, early birth, preterm labour, risk of preeclampsia, and neonatal poor outcome if they have a baby who is born earlier. So we've talked about metformin being an alternative. You need to be talking to the patient to ensure we understand why she may have not been on metformin. It may be something that she's not been able to tolerate, and we need to highlight that and think about what alternatives they would be. And of course, to be warning them about risk of hypoglycemia, which is less common with metformin, but nonetheless, they are very common symptoms of pregnancy, which also mimics symptoms of hypoglycemia, and we just need to make sure that they are on board with that. The next case is of a case of a lady with hypertension who is on lisinopril. Now, I'm sure you're all very familiar with ACE inhibitors not being advised to be taken particularly in the first trimester. They have been associated with stillbirth and oligohydramnios, and we have plenty other pharmacological agents that are appropriate for blood pressure control. I've put the list down here. I'm sure a majority of you are incredibly familiar and used things like beta blockers, labetalol, nifedipine, which is a calcium channel blocker, methyl dopa, which has been used for many years, but we tend not to go for it as the first-line treatment, as it does make women feel unwell and it's essentially acting so people are lethargic and very tired on it. My second last case is a lady with hypothyroidism. She is on carbimazole. This is a drug that basically blocks the production of thyroid hormone, so reduces the effects of having lots of thyroid hormone going around, the symptoms of anxiety, sweating, weight loss, diarrhea, etc. And the question is, should she be carrying on with carbimazole? Now, both carbimazole and propylthiouracil can be used in pregnancy. I think propylthiouracil is the preferred choice, and again, it is a matter of taking a good history and finding out why she may be on carbimazole. Had she been started on propylthiouracil? Has she had some issues with it? And whether she has been given enough information about side effects for both of those. Untreated hypothyroidism has adverse outcomes in pregnancy, therefore it's really important that we have that conversation about maintaining the woman in a euthyroid status and ensuring that the baby is being monitored. And again, once you have that knowledge that they have hyperthyroidism, it's very important that a referral is gone to maternal medicine review, or if you've got a joint endocrinology and obstetric team, so they can look at them, find out what drugs they're on. Again, may need to run a few tests to also evaluate possible side effects of the disease, and if there is other issues that for the baby that needs to be looked at. My final case is about a lady who has had a renal transplant. She's on immune suppressant therapy with azathioprine and prednisolone, as well as tacrolimus, and she is concerned. She understands about her immunosuppressant and the importance of it, but she is having a concern about safety of it and concern. And really to reassure everyone that a lot of immunosuppressants, be it in renal transplant, be it in autoimmune arthropathies, be it in autoimmune dermatological setting or gastroenterology, for inflammatory bowel disease, for rheumatoid arthritis, for SLE, by and large, a majority of them are safe in pregnancy. Therefore, you need to ensure that if they were planning a pregnancy or early in pregnancy, the better the disease is controlled, the more likely they will end up with a successful pregnancy. We know that if they have a renal transplant and they have a rejection, they really are not going to be able to conceive, or they are going to get into trouble during their pregnancies. Equally, if they have rheumatoid arthritis and they have a flare, inflammatory flare, their risk of preterm labour, of small for gestation baby, and complications for themselves and the baby are far greater. So the last slide is about safety of most of the drugs for common or minor illnesses such as antiemetics, antacids, some analgesia, and constipation. I'm going to leave this slide up for a few minutes more, sorry, a few seconds more. I don't think I've got that much time, just in case anybody wants to take some notes. And I'd like to summarise by saying I hope that the review of some pharmacology and physiological changes has been helpful for you to think about how the drugs may be handled. Going through stages of fetal development has reminded you about the effects on anatomical development and major anatomical malformation versus perhaps growth and development of the baby later on in pregnancy. Always thinking about the risk versus benefit, the value of taking a very good drug history, and the importance of having a healthy mother in order to having a healthy mother and a healthy baby at the end of the pregnancy. And thank you very much for your attention.